Hi everyone. Thank you so much for coming to our Global Health Leader Seminar today. We are joined by Dr. Yazdi, who is going to get an excellent introduction in just a second, but we're really excited to welcome you and continue our series where we hear from wonderful global health leaders about what they're doing. So with that, I'm going to pass it to the director of our center, the Center for Global Women's Health Technologies, Dr. Remy, Nimi Ramanujam, and she will introduce our speaker and we will get started.
Great, thank you, Ashley. Well, it's great to have Dr. Yazdi speak to our community. I've known Yusuf for a long time, maybe 30 years, and it's impressive how he went from being a PhD student to now directing a really exciting and innovative center at Johns Hopkins. So Yusuf has a master's PhD as well as an MBA. And prior to his directorship at the Center for Biomedical Technologies, he was the corporate director at Johnson & Johnson's Office of Science and Technology, where he was responsible for leading external partnerships and internal partnerships to essentially guide early stage healthcare innovation. And so his background is ideally suited for the activities you'll hear about at CBIT. And he is not only having meaningful impact through technology innovations, he's essentially spurring a generation of young innovators who are taking technologies from concept to meaningful impact and understanding along the way the twists and turns that occur when you're thinking about frugal or low-cost affordable technologies for global health, as well as for any environment where there's a need that needs to be fulfilled. So with that, I'll turn it over to Dr. Yazdi, and I look forward to hearing your talk.
Thank you so much, Professor Ramanujam. That's a wonderful introduction. I look fondly back at our experience as a PhD student, and I thought that was what PhDs were like, working with Dr. Rebecca Richards-Gordon, and then I realized a lot of people spent their whole career in a lab someplace, and we were blessed to have a professor who sent us out to the clinic and forced us to see where the patients are and to observe and see the context in which the problem exists. And that has really been an inspiration my entire career. And I assume your students do the same now. When you're PhD students, you send them out and force them out to get out of the lab and see things. So it's a different type of experience. Thank you so much for the opportunity to talk. I'm going to try to wrap up by 12:30 and then leave some time for your questions. And if you have any questions in the middle, you can raise your hand or ask them in the chat, and I'll watch for them too. I love this picture of our class. This is one of my favorite pictures because it really tells the whole story of what we do. And it's 4 of our graduate students in the CBIT master's program in a maternity clinic in Nepal. And the woman seated talking to them is a midwife there in that clinic. And you can see behind her the different tools she uses to manage the cases. But what I love the most about it are 2 things. One is the diversity of the class. So there's a student from Taiwan, from India, from Singapore, from USA. And I also love the fact that they're listening intently and taking notes. And this is everything we do in design is really based on this idea of really carefully understanding what the problem is, listening carefully. Satya Nadella, who is the head of Microsoft, gave a great interview in the Harvard Business Review just 2 or 3 days ago. If you Google it, it's in Inc. magazine also. And he says the #1 trait that I look for in people that's essential for success, that's not really taught anywhere, is empathy. Empathy. That's the #1 trait, the ability to understand what's going on in the mind of the people you're trying to help. And if you can't do that, you can't create good products. Now, he's thinking about it from the perspective of product design, but it's important in so many different ways. So that's why I chose this as the starting slide. So I'll go through the rest of these. What is design? If you're not in the world of design, you may think design is about making pretty objects. In our case, it's design is to create a good solution to a problem. That's really what design is all about. The first company I went to work for after I left UT Austin and my PhD was Ethicon Endosurgery, and this is what kind of the products they make. It is, of course, quite attractive product. It looks very sleek and cool, but it's incredibly useful. It saves lives. It allows surgeons to take out your gallbladder through a tiny little holes, and is really now the standard of care. It cuts and staples in one shot, easy to use, easy to understand how to use, and this is a good solution to a problem. This is good design. Poor design can also look really good. I mean, I don't know if you have one of these at home. I apologize. They're like $30, $40 at Williams-Sonoma. They're the most incredibly useless fruit juicer you can ever purchase. If you ever try to juice a lemon, you'll have lemon juice all over the countertop. It'll be a mess. Probably most useful if if you have a home intruder, you could use it, I guess, to defend yourself. But it's really looks nice, but it's useless. And there's so many ways that things can be poorly designed. They could be non-functional and not doing the job they're supposed to be doing, like this fruit juicer. They could be not effective in doing that. They could be unsafe or just not usable in the sense that it's not easy to figure out how to use them. Or they could be not affordable or not buildable. What's the use of making something that is impossible to manufacture at scale and at cost? Or not sustainable in that it's creating a lot of waste. Or it's just not better than what's already out there. And the bottom line is it's not going to be valuable to other people, and it's not a good use of your time and your creativity. I don't know how many of your students, Dr. Ramanujam, have to take an ethics in biomedical engineering or ethics in engineering class, part of their undergrad curriculum. But one thing they don't teach you in ethics, which is probably the most important ethical issue, and that is your choice in how you deploy your talents, your creativity, and your time, and how you're going to use them. That's probably the number one ethical issue we all face. And it's so important not to waste that on things that just don't help anybody. Good design, on the other hand, improves health, lowers pain, automates something, de-skills something. What that means is it's something that requires high level of skill. Maybe suddenly somebody with a low level of skill can do it. Like something that, let's say, maybe a super specialist, now you allow somebody with less specialty to do it. Somebody, something that requires, let's say, a physician now, like a nurse could do it, or something requires a nurse in the hospital, now it could be done in a remote clinic, or it could be done even at home. And things that improve training, lower risk associated with the solution, reduce waste to the environment or wasted resources, or increases access, makes a solution that makes the care more available to people, available to more people, or empowers people, gives people, an individual, the ability to manage their own health. Those are all elements of good design. Here's some examples of projects we've done in the past. They range from really complex. This is an ERCP procedure that we worked on with Boston Sci. It was a procedure which is done a lot, very effective, but it's really hard to do. So, and we worked with a group in India, the Indian Institute of Gastroenterology in Hyderabad, on how to make it so that more people with lesser skill could figure out how to do this right. The key is getting this little wire here into this duct, the common bile duct, instead of the pancreatic duct, because if it goes in here, you're going to get pancreatitis. So, so we designed a way to make that easier to do. This one over here is an ultrasound project. How do you de-skill ultrasound? If you've ever looked at an ultrasound image, you'll see it's really hard to do ultrasound. It's not like MRI or CT where it's crystal clear what's going on. And the team came up with a way to de-skill it, and I can tell you about that later if we have time. So design is really then a journey that starts with empathy and passion. These are, by the way, photographs taken by our master students. This was in Bali Island in the Sundarbans in the Bay of Bengal, an actual surgical suite. 100,000 people on this island with no doctors, only rural medical practitioners. We met some people who actually had surgery here. It really starts with what the CEO of Medtronic talked about as the #1 trait when you go to interview that they're going to be looking for if they're a good company, and that is empathy. The ability to put your understand not only what the needs and concerns are of the people you're helping, but the environment in which they live and the concerns they have. And that should lead to careful and clear and respectful understanding. Here's another photo from India. This is a very top-end super specialty cardiology clinic in Hyderabad. The woman seated here is one of the top cardiologists in India. And these two are students from CBID taking careful notes again, listening very carefully. One of them just left Medtronic and came to CBID to do the master's program. And she said, it's amazing. I never did this when I worked in the company. So what does it take to be successful? Let me tell you a little bit about our design thinking. First of all, to be successful in solving a problem in medicine requires you to think about 100 different things. Medicine is incredibly complicated because the person being helped and the person providing the help and the person paying for the help and the person providing the facilities and making the devices are all like different, they have different stakeholders and different concerns. There's 100 different things you have to think about. It's like boiling the ocean. So how could you ever be successful in this unless you have a team and $10 million to work on this? But there is a way. What we do is one way to think about it is to simplify, arrange all of these different issues into 4 thematic areas: clinical issues, commercial issues, which have to do with regulation, competition, all those things that a business leader would have to do, technical and design issues, which you're taught a lot about in engineering, and organizational strategic issues. Do you have the right team? Do you have the right interest? Does it align with your interest and those of your partners? Do you have the right funding in place? Does it align with your strategy of you and your partners? Those are 4 thematic areas. So you can take all of those things I talked about and arrange them into 4 categories. Now, typically, this is what happens. How many times in academia have you heard the word bench to bedside? Typically, what happens is that you're really good at one thing. And I can tell you, my advisor, Rebecca, she was awesome. She said, Yusuf, you can work on whatever you want to work on, but it better end up using a laser as the solution, because that's what we do in our lab. We're an optical spectroscopy lab. So, can't be tissue engineering. And that's typically what academics do. You do a lot of technical development. You don't pay a lot of attention to the clinical, commercial, and organizational issues until much, much later. The problem is that you could end up spending decades designing and developing something technically, and if you don't pay attention to these other factors, you're never going to help anybody. You have to come up with something that makes sense from all of these perspectives. Now, a better approach is to start with the clinical problem, of course. Understand the clinical problem. Once you've fully understood the clinical problem, then design a solution. Once you design the solution, then design a business plan around that. And once you design the business plan, then you put together the team and the resources to develop it, right? Nice, linear process. Anybody see a problem with this? First one to comment gets 3 points, right?
Can I get 6?
Yeah, all right. What's the problem?
Well, one problem is that if you're not backcasting, you've probably spent a lot of these resources only to maybe fall on your face.
Yeah.
I know that's a bit negative, but maybe there are others that.
Excellent, excellent. Your students are ahead of you, Dr. Ramanujam. Yeah. Good. Yeah, you're right. You're right. The result is gonna be failure also. I think there's a little bit of arrogance in this too. And I remember at J&J when I first started, we would interview like people from Case Western and Cleveland Clinic, and the surgeon would come in and say, this is what I need. And they would say, I need a better one of these. And then you'd go off and spend $1 million and come back and show him this. And he'd say, now that I see it, that's really not what I needed. I just needed a better way to highlight text. I didn't really need a blue highlighter, so you can't assume you fully understood the clinical problem and then start trying to solve it. It's not a viable assumption. This is more like hiking in the mountains. You can see 10 steps ahead of you. You can't see all the way to your destination. But until you take those 10 steps, you're not going to see the next 10 steps. So this approach is a much better, but as Megan said, nothing's really linear in real life. So a better approach is to start, of course, with the clinical understanding, then start to assess what are some of the commercial constraints, like how much are people really willing to pay for this? And what are some of the regulatory constraints on this, on solving this problem? This is before you even have a solution. Then you start doing some initial thoughts around how you're going to solve it. And then you start thinking about, do I have the right people and the right interest in this? And then you go back to the clinic and see if this still makes sense. You go back to the doctors and say, this is what we've realized so far. These are our preliminary ideas. Does this still make sense? And you do it again. That's the process that we're implementing. So think of it as a Cartesian coordinates, where this space here is money and time that you're going to spend, starting at time 0, $0, and you're going to fill up this whole space in order to succeed. Clinical, commercial, technical, and organizational issues all have to be addressed. How are you going to address it all? You don't have that kind of money. Nobody does. And if you throw that kind of money at it, you're going to end up with a lot of late-stage failures. The approach we take is this, an iterative approach. You do the first iteration, you do a little bit of work understanding the clinical needs, understanding the commercial value, understanding develop maybe some initial ideas, put together the right team, then stop. Stop, make sure that your project makes sense from all 4 of these perspectives. If it does, go forward. If it doesn't, kill it or pivot to something else. You may decide that this really, we thought we had a great project, but it's not worth pursuing based on all of these considerations. And if it makes sense, then you go to greater depth in all of these. Your initial conversation may be with 1 doctor or 1 clinician. Your next conversation may be with 10. Your initial conversation about regulatory issues may be a 15-minute conversation with somebody who knows something about FDA regulations. The next iteration will be a 1-day review. And at CBID, we go through like 3 of these iterations, including ending with a review at the FDA, doing a mock pre-sub meeting with them. Your initial designs may be back of the envelope 2D drawings, and then you go to 3D prototypes, and then you go to more sophisticated looks like prototypes later on. But in every iteration, you stop and you make sure that everything is still on track and makes sense before you go further. This is the process we follow. Now, there are hundreds of needs that can emerge from your observations and when you go and see a situation. And Paul Yock has a quote that I really love, and that is that the unsung hero of innovation is choosing the right problem to solve. And the needs can not just the acute need where care is delivered, but also not the 1% of the time when the patient's in the hospital getting care, but the 90% of the time before and after when the patient's being diagnosed or treated or after treatment at home and maintaining the care. All of those things you have to listen for very carefully. And when you're assessing the need, you have to assess, even in choosing the right need, use all 4 of these criteria. Is this problem causing significant harm to patients? Does the intuition of the doctors tell you that this should be solvable? Are the doctors telling you that this solution, the existing solutions, are just not adequate? There's got to be something better. And on the commercial side, is the impact of the problem big enough financially that people are willing to pay, and how much are they willing to pay for a solution? And can we articulate a clear value proposition that if we solve this problem, these are the people who benefit and this is how much they'll benefit? And because we're engineers, we have an engineering intuition. That's the number one thing you get as an engineer. Engineering intuition will tell you that this is solvable using existing science and technology. It's not going to require like an infinite, anti-gravity machine or a perpetual motion machine. It probably should be done, doable. And then you go back, ask more questions, and then once you've chosen the target, you look at hundreds of ways to solve it. It's not that it has to be a laser. It can be anything that solves the problem best. It could be a new device or tool or a new app, a new educational program. One of our projects in global health ended up with a poster on how to improve the decision-making around normal versus C-section for midwives. Or it could be a combination of these. Your goal is not to prove you're a great engineer or a great scientist. Your goal is to help people and solve their problems. And you have to go back repeatedly. So let me tie this back to global health innovation in particular. It's really important, even if you're not going to do global health innovation your whole career, when you go for a job interview and you say you know how to solve problems in a frugal manner, in a low-cost way, it's incredibly important for you. And in fact, most of the growth in our industry, it's a $5 trillion industry, most of the growth is in emerging markets. It's in middle-class India, middle-class China, middle-class Brazil. Those are people who now have enough money, and the first thing people demand is better healthcare. But they're not going to be able to afford things at the top of the pyramid. They need things that are more, affordable. So this is a key skill that you'll develop if you work on these global health projects. I'm going to try to go a little faster, and I think it's a duty that we have in our programs to teach these approaches. And it's beyond this us versus them mentality, first world versus third world. It's all about figuring out how to solve problems in the most efficient, cost-efficient manner. And even in the US, the cost constraints are such that this skill that you develop in working in global health innovation will be immediately applicable here in the US. And I'll bring you some examples of that. At J&J, we had this product called the One-Touch Ultra Smart. And it was built by our company in Fremont, California. And it was incredibly expensive. It was like $75, but it had charts and graphs and amazing product. And the team in India said, hey, listen, guys, this is amazing, but in India, no one's going to buy a $75 thing. This is going to take a year to figure out how to use properly. No one's going to use all these features. Can we make something really low cost for this market? And around $10 is what people are willing to pay. And the company back home said, oh, heck no, because then that product will end up cannibalizing our market here. But then they promised up and down they'll never sell in the US, it'll be just for the Indian market. So they came up with this amazing, cost only $5 to make, the One-Touch, mini. You plug in the little I don't know if you ever seen one of these, you plug in a little strip and it tells you the number and that's it. Simple, one button, not 50 buttons, and it's dirt cheap. By the way, the team in India actually went to the point where they took out the last button too, and you just put in the strip and it automatically comes on, and it plays a little jingle, a little Bollywood jingle, if your glucose is good or glucose is bad. I guess there's a sad Bollywood jingle, and it'll tell you like where you stand. And then, by the way, if you go to CVS today, you'll see it right there on the shelf, and it's there. Of course, they put 2 buttons on it, but it's still, and it did cannibalize the market for that more expensive product. That's reverse innovation. You designed it for frugality, for simplicity, and bingo, guess what? Americans also value those things, not just people in India. So at CBID, we've done projects in all these countries. It's part of our program. We, of course, each student does 2 projects on 2 teams. On the same team does 2 projects. One focused on the US and wealthy healthcare systems like Hopkins or Duke or MGH. And then one project focused on lower resource settings. Increasingly, they're in the US too, but also in Brazil and India, Sub-Saharan Africa, China. We've done projects in all these places. We've even been to the jungles of Guinea during the Ebola crisis, doing projects with PPE and the develop innovation in personal protective gear. I'll give you a couple of really quick examples because Dr. Ramanujam wanted me to give some concrete examples for you. So the team visited a clinic in Kenya, rural cervical cancer screening clinic, and they found that a lot of women are presenting with late stage lesions and tumors. And it's because the idea is to do see and treat. When you see something early on, treat them right there because they're going to leave. You may never see that patient again. So if you can do a see and treat, you're much more effective in treatment. And the tool they use typically is this cryoablation tool at the top here. It uses CO2, usually acquired from the Coca-Cola factory nearby, and it pushes the CO2 through this tip, and it freezes the tip, and it's pressed against the cervix, and it freezes the tissue, cryoablation. Except it breaks down a lot, it gets clogged, etc. So the team was challenged, come up with a way that's cheaper, easier to maintain, easier to use, easier to carry around, and they came up with this thing called CryoPop. And basically, you turn the canister upside down, you get the liquid part of the CO2, and you feed it into this little channel here in the front of this piece of plastic, and it creates a block of dry ice. Then you press the dry ice onto the cervix, and it does the same cryo freezing ablation. You have to follow a certain protocol back and forth. And it has the same clinical effect of this product, and it only costs like $10. And the CO2 evaporates, there's no tubes to clog up, and it works really, really well. And now it's on the market, sold by Pregna outside the US so far, and just got on the market, a few months ago, called the CryoPop. And it's saving lives and fighting cervical cancer. Another product is tissue analytics. The team had an idea. They saw a lot of management of chronic wounds was really bad, and measurement error in measuring these wounds was like 40%, 50% inconsistency between nurses, and it took like a minute to measure the wound, so it was a waste of time, and it wasn't really working well. So they thought of, well, how can we improve this? And they know one technology that's ubiquitous is cell phones. So can we use a camera on cell phones to make this measurement more precisely? And they came up with an app that does it, called Tissue Analytics. It basically takes a photo of the wound, and using some spectroscopy, they can basically, with reflected light in the visible spectrum, they can figure out some characteristics of the wound, like whether it's necrotic or healing well. They can exactly determine with 5% measurement error, less than 5% measurement error, the size of the wound. Let me ask you guys a question for 5 points. Given that your camera could be at any distance from the wound and at any angle, and the illumination is going to be different, how did they get it down to 5% error? This is a handheld phone. You're holding the phone, okay, like this, over the wound, and it could be like, up or down or at an angle or whatever. So how did they figure that out? Oh my gosh, Erica, 5 points for Gryffindor. Okay, the reference sticker. Excellent, thank you. So I sent the team to the office supply store. I said, I want you to buy a box of 1,000 of these little dots that we put on these files, folders. And you want one box because they're all the same print, so they have the same color and everything, consistency. And every time the nurse wants to take a photo, they put one of these dots on there. Now from the dot, you can get the angle, you can get the distance, you can get the illumination, and do all that calibration. Excellent, Eric. And that became a very successful company, Tissue Analytics. In fact, they were recently acquired. They all had a great exit and made some money. It took them 4 years after CBIT, but they did pretty well. Another one is in telehealth. And this is a project that came out of our visit to India, where we realized that the biggest problem in getting good care was the person in the front lines did not know how to do a good job of figuring out what's wrong with the patient. They did a lot of guessing. They would give you a lot of medicines that didn't really help. 50% of Indian citizens, the first person they see when they have a health problem is not a doctor, it's a rural medical practitioner, RMP. And those folks did not have good enough training to do a good job. Even in the US, doctors don't do a good job of this initial triage and figuring out what's wrong with the patient. So the team went through the textbooks, found 100 rules on ways, the questions that doctors ask to narrow down what's wrong with the patient. They put those rules in an app, and they create a program called Telehealth that captures all of that, that leads a rural clinician, a rural healthcare worker in a clinic. These are normally high school women who are trained in the program for 6 months, and then they're given this app, and they use the app to ask questions, and the app guides them through different questions and says, okay, they do a really good job of capturing the needs and the situation of the patient. They transfer those records over low bandwidth 2G signal back to a doctor who confirms quickly because he has all the information categorized there, and they can go on to get much better care through this method. And this company is spun out from CBIT now. They just reached $1 million in revenue. They have 50 employees in India and a few here in the US, doing very, very well, especially during COVID. So look them up, telehealth.org, not-for-profit company. Another one we're doing this semester is on India and eye care. And India bears the greatest burden in the world in eye disease. And one of the biggest challenges is getting people into the funnel to get low-cost eye care. And they're great, excellent facilities like the Arvind Eye Institute for that. And so the students have developed a screening tool using a cell phone again that use AI, and they're doing the artificial intelligence to detect the cataract, and their performance is pretty good so far with small numbers. And actually, one of those team members is in Madurai right now, looking at doing some of these at these rural screening clinics to capture images to train the AI system. Now, Dr. Ramanujam asked about sustainability and business models that make these things sustainable, and that's one of the elements. It's that second quadrant that's so critical. It's useless to develop a solution if you don't have a way to actually make it viable in the marketplace. So in this case, the students have designed 3 models for making this sustainable. So they do a thorough analysis of this. They bring examples of successful implementation of these different models. They get business courses and training and mentorship as well as part of the program to do this. So that's what happens. It's this iterative model that you and your teammates will go together with, of course, the right mentorship. Each year we have 4 or 5 teams and 4 or 5 people on each team combined with 4 or 5 mentors. Nice design studio space. It's a good group. This year we're working on, for the US projects, we're working on a project in pancreatic cancer to deliver radiation in a 3-dimensional way to improve outcomes. A project to monitor for lymphedema using spectroscopy or some other technique. A project to reduce bleeding in kidney biopsy, and a project to reduce kyphosis after spinal fusions. So those are the 4 projects, and then 5 projects actually. Then for the global health projects, is a project to automate looking for parasites and samples for a project to actually count mosquitoes for getting the genus and species of the mosquitoes, then train entomologists in the field. And they have one of the largest databases of images of mosquitoes. Another project for eye screening, like the one I talked about, and another project that's training surgeons in Kenya how to do laparoscopic surgery, minimally invasive surgery. So most of our graduates end up in industry. Some go to grad school, medical school, etc. About 1 out of 8 go into one of our startups, and some go to government like FDA and other organizations like that. We've had some good spin-outs from the group, like in telehealth, Sonovex, and others. Sonovex was the de-skilling of the ultrasound project, which is doing really well. And check us out. Our applications are due December 31st. The program starts June 1st. We actually have an info session tonight from 6 to 7 on Zoom if you want to learn more. 35 minutes.
Thank you. That was amazing. Yusuf, before I forget, can you send the link for the thing tonight so that I still like to write things down?
Yeah, I'm going to. Yeah. Okay. Let me highlight.
Oh, it's right there. Sorry.
Yeah. I'm going to, but let me put the link in the chat here too. So if you, that's for tonight. Tonight, 6 to 7 p.m. If you can, there's another one a month from now. If you go to our website, which is cbid.bme.jhu.edu, you can. There's also a few other. There's one other info session after tonight. If you can't make it tonight, but if you have any questions, feel free to contact me. So I can go back to the slide on the global health or whatever questions you have. Let's get into that.
I have a handful of questions that have been sent to me directly from the chat, so I'll just read one or
Sure.
two, and then if people want to raise their hands or just unmute themselves or ask in the chat as well, any of that's fine, but I'll just go ahead and start reading questions. So I have one that reads, how do you go about identifying who the key stakeholders are for a new design problem, and how do you recommend engaging them?
Excellent question. This is a really, really important starting point. You have to ask yourself, what is the problem you're dealing with and who is impacted by this problem? Especially for global health, it's not just the patient. It's the family members often as well are critical in this, much more so than in the US. The loved one that has to take a day off and take a bus to go to the hospital and lose a day of wages. The person who has to take care of the kids at home, or the person who's got to pay for there's often a trade-off. Should I send my kids to school, or should I pay for this treatment? Those are stakeholders that we often don't think about. Usually in industry, we talk about, in business school, we talk about the 4 Ps: the payer, the patient, the physician, and the provider. Provider meaning the hospital system. So the 4 Ps: physician, patient, payer, provider. There are also all the other, in addition, when we say physician, there's also other healthcare workers involved. Especially in global health, you get involved with much more, and you have to really talk to all the caregivers that are involved. So the best way to do it, I think, is to look at this 4-quadrant approach and say, who are all the stakeholders on the commercial side? That means people who are going to invest in your product, in your thing, the people who are going to pay for it, people who are going to regulate it, the competition who are out there already. On the clinical side, who are all the people that are important on the clinical side? The family, the patient, the caregivers, both the super specialists and the nurses and community health workers, etc. On the organizational side, there's stakeholders there. You are a stakeholder. Do you have a passion for this problem? Do your teammates have a passion for the problem? On the technical side, the technical expertise areas you're going to need to solve the problem. So those are all different stakeholders, but you probably want to start with this clinical stakeholders to really make sure you have something that's worth solving.
Yeah, that's fantastic. I'm going to ask one more that was sent to me privately, and then maybe I'll let someone unmute or ask in person. But this is, how do you address cultural barriers or ethical concerns?
You know, especially when it comes to global health, the ethical concerns are really critical, because one of the biggest issues come up when people are not empowered. When people have less power, the ethical concerns become rife, and that's why it's so important to understand the stakeholders, understand what they're going through, what their issues are. It's really important to understand empowerment and disempowerment when you're solving a global health problem. You have to realize that when you're, for example, asking people questions about their condition, that you're doing it in the most ethical manner. And people are often very hopeful when they see you showing up from the United States to help them out. Hi, I'm here to rescue you. I'm from the United States of America, and that really distorts behavior, distorts opinions, and you want to be very, very cognizant of that and your role. You want to make sure you understand the power structures within where the problem exists, and in designing a solution, you have to address those power relationships. For example, we had a project here at Hopkins years ago on reducing infection for central lines, and even though the protocols were very clear, the results weren't good. And the head of the program found out the reason why. The reason why is that years ago, there was a very male-dominated situation with doctors and nurses, where it was kind of a machismo thing, where the nurses would not dare tell the doctor that you're not following the protocol. The nurses were trained in the protocol. They were doing really well. But if a doctor came in and didn't do the protocol properly, didn't wash their hands properly, or didn't disinfect things properly, the nurses were loath to stand up to say something against that person. So the head of the program gave his cell phone number to all of the nurses in the program and said, if anybody gives you any flack, just call me and I'll straighten them out. Now, that's not the best way to solve the problem. The best way to solve the problem is that people should be empowered and it shouldn't be an issue. But in global health, it is an issue, and you have to be very cognizant of that. The cost burden on a family is really critical. You also have to be very careful about imposing your own cultural values on a society. You don't know what's going on in that society. If someone chooses not to care and provide the best care for a loved one, it could be because to do so may require taking money away from the education of their child, or food for their child, or proper nutrition for their child. It's not for you to judge. You need to make sure that you listen very carefully. And lastly, involvement and engagement. If you want to design something for global health, you have to engage and involve local people, the people you're trying to serve, in the whole design process. That's been difficult in the past, but through programs like Rice 360's NEST program, increasingly the talent and the resources are there, and you should try to make that a core part of what you do.
That's fantastic. I said I would stop and let someone unmute, but I'm just going to ask this one more that was in the chat because it seems very relevant to what you were just saying. Someone says, thank you for your talk. I'm very interested in learning more about your work with the community health workers and rural health workers, such as the example given about triage care in India. Could you discuss how you engage with your networks and collaborators to meet these folks where they are and involve them in the design process? Thank you.
So it's hard. Just like at a hospital like Duke, you can't walk into the hospital and just start talking to people. You need to have fixers and arrangers and people who are your partners and allies inside. At CBID, we have global health, we have clinical directors too that we pay to spend, they're doctors at the hospital, to spend time with their peers to open doors for our students. On the global health side, we have to do the same. So we work with partners on the ground to make sure we have the proper safety not only for our students, but also for the people involved on the ground there. Protocols in place. So we've had all sorts of partners in place, facilitated by sponsors like USAID or JPIGO or other organizations. Some of them are organic people that we know. The head of the master's program here is a native of India and a physician from India, Dr. Acharya, and he also had some excellent connections in the Calcutta area in that state, West Bengal, which allowed us a lot of access. So it takes some effort, I would say. It's not easy, and you want to do a lot of planning and make sure you have things worked out. Often it requires resources, so you want to make sure you're spending money to compensate people for their time and investment in your visit and your opportunity that they're creating there on the ground.
Can I interrupt and ask a question? I'm sorry, I can't do it the new way. I have to do it the old-fashioned way. I'm very interested in this whole idea of sustainability. So let's say you have an amazing technology, it's very affordable, you need a distributor, presumably to have a wide reach. And so you get it to a distributor, but they can, do what they need to make a profit. And it could very well be that you're thinking 2x, they're thinking 8x, right? And unless, I guess, you have some strict arrangements, right? So they can do that, which means that you ultimately target a certain segment of the market and exclude others. So how do you address the problem of, yes, you want wide reach, you can't reach everybody yourself, but at the same time, people's incentives are not aligned with yours?
Excellent.
Did I just confuse you?
No, I think that's really critical. That's where this fourth quadrant is so important: organizational strategic issues that people often neglect in design. They pay, the best designers will pay attention to clinical and commercial and technical areas, but oftentimes people neglect this fourth critical quadrant. And as you have good partners in place and you have alignment and agreements in place to ensure that the mission of the project is maintained. For example, we worked with Lærdal Global Health, which is a global health spinoff from Lærdal Medical in Norway. And we had an agreement in place with them that whatever innovations came out of our program, our partnership, that they would sell at low cost with a maximum profit margin of 20% in low and middle income countries. If they want to, they can make a ton of money in the US and Norway or Europe, wherever they want. They also committed that excess profits from those would come back to the program, above a certain amount. But you're absolutely right. You have to know who you're working with and make sure they're good partners. And I give you an example. GE came up with this amazing ultrasound device called the V-Scan, which was a handheld like a stethoscope, but it did ultrasound, and it sold really well in India. And it turned out that in some countries, India and China, and some places, it was being used for gender selective abortions. And it was illegal. It's illegal in both countries to do that, but people were using it unscrupulously. So the question is GE responsible for that? They say, well, it's not our business. We made a device, we sell it, but the vendors who were selling it in India and in China were being unscrupulous and pitching it for that purpose to doctors who were unscrupulous about their practices. So the company said we can't absolve ourselves of responsibility for how our products are being used. We cannot. We have to take responsibility, and we have to implement programs to prevent that from happening as much as possible. Mm-hmm. And that's what they did. They had all sorts of educational programs, etc. But I think it's something. I think Dr. Ramanujam, is critical that the part of this iterative model is that you think about those issues every iteration of your design. You don't wait until later to think about that. All of these issues that we're discussing are things you have to think about from the very beginning. Every time a student asks me, when should I start thinking about X? My answer is always now. The question is not when, the question is to what extent. Yeah. You can't do a full regulatory analysis right now. You can do a little bit. You can do a little bit of looking into who are good distribution partners in India that have a good reputation, that care about this. And we've identified some, like the Arvind Eye Institute, that's world famous for doing low cost and free, cataract surgery and other eye surgeries, those sort of things.
Can I ask a follow-up question to that? Because you were talking about the ethics on the buyer side. But I also want to bring up that in my own experience, and I'm not going to, talk about specific technologies, I've noticed that, funders, they sometimes just want to get the money out to solve the problem, right? Because they have stipulations to meet their milestones. So I've often seen that, say you have two technologies, one is superior in quality and naturally slightly more expensive, and you have a really cheap technology that's subpar. What's the inclination for a funder? They're going to go with the cheaper solution because they can get more products. So that's on the designer side, right? Like you can be disruptive, like, with Intel and other examples, but in that case, they start maybe with not as exquisite a technology and they work work up to something that's on par. Here, there's no room for that.
Well, it's a good challenge, I would say. I think that we have a moral imperative to have the most impact. And if a device has 80% of the functionality and can reach 10 times more people versus a device that has 100% of the best of functionality but can only reach a percentage of the people. I remember I went to this lecture, this gentleman had prosthetic legs. I'll mention his name, Hare. He's famous for prostheses at MIT. He wears the legs himself and he designed them. They're like $1 million a piece, but they're incredible. He could run up and down the stage. He gave a TED talk, running up and down the stage with these prosthetic legs. And I said, after I approached him, I said, "Are you interested in working with us to design something that would have like half the functionality, but a fraction of the cost?" And he said, "Absolutely not. I don't want to remove any of the functionality. People deserve to have the best of the best, but people can't afford the best of the best. So if you want to have an impact, you have to make that decision." And say, what am I here to do? Am I here to prove that I'm a fantastic, the best engineer in the world? Or am I here to help people, the most people? I think it was um, uh, Wellesley, the founder of one of the Christian sects in the U.S., who said your goal should be helping the most people in the most way, in the maximum number of possible ways, in the maximum number of people for the most length of time possible. And it's all about maximizing impact.
So I'm going to turn my mute button on because I think there are other questions.
I do have 2 questions that have come in from the chat, but I just want to leave a space if someone has been saving their question to ask. You can go ahead and unmute yourselves now, and I'll give you like 30 seconds. And if no one does, then I'll continue with the questions from the chat. Okay, so I have one question that reads, I was curious if you and your team have tried scaling a similar program down to target younger undergrads or high schoolers, and if so, what part of the design process did you supplement or freeze to simplify the process for those students?
So you can simplify the needs discovery part, which is really time consuming. So at CBIT, we spend, if you think of the whole year, 1/3 of the year, the first third, is spent on clinical immersion, identifying hundreds of needs and picking one to focus on. The second third, identifying hundreds of ways to solve the problem and narrowing down to one top solution. The last third, taking that top solution and evaluating it and developing a business plan to implement it, etc. So you can short circuit it by giving like undergrads or high school students a design challenge and say, okay, today we're all going to focus on ways to solve this problem. Now you want to give them a little bit of chance to understand the problem a little bit in greater depth. So we've done emergency design challenges where we've had like 100 students come in, high school students, college students, whatever. We did one during the Ebola crisis, the Zika crisis, the humanitarian health crisis, and during the COVID crisis. And we've and usually it starts with, okay, here's some predefined needs that the experts are telling us there's a desperate need for X, Y, Z. You don't need to go and rediscover that and reevaluate that. I'm telling you it's really needed. And they're willing to pay $10 a pop for a quick diagnostic test, whatever. Sorry. But that's one way to reduce the time on the procedure. But I think doing like one iteration of the design where you don't go too far, but you touch on all those factors, I think would be a good way to do it. Another way to reduce the complexity of the effort.
Yeah, that's fantastic. And then one, I think probably final question is, I thank you for speaking with us. I'm intrigued by your earlier comment that the question of, is this a good use of my time and creativity is one of the most important ethical questions to ask. Can you elaborate on this?
At the end of the day, we're all blessed with certain resources: intellect, healthy environment to live in, a clean, nice office, air conditioning, heating, lighting, electricity that works like 99.9% of the time. I'm not being attacked or thrown in jail for my views. We are all incredibly blessed here. We have intelligence. You're at Duke University, one of the finest academic institutions in the planet, in history, at the pinnacle of world, global human civilization. You have an obligation that imposes a very steep obligation on each and every one of you. All of these resources that you have an obligation morally to do the best you possibly can with those resources. Now you can think of your life also kind of like in this 4 quadrants. Think of your life and think of the things that are important for you. Maybe your family, and society and community. That's maybe one quadrant. Another quadrant may be your spiritual health. Another quadrant may be the access to resources you need to get things done, wealth and finances and those sort of things. Another quadrant may be your physical health. And think about developing your own life the way you design a product and do it in a balanced way. If you focus only on money and you look for jobs and take the job that gives you the highest salary, you're not going to be happy in the long run. You may end up with a huge 10,000 square foot McMansion, but you're not going to be happy because you're going to look back and say, what a waste. I could have used all those resources I had, including my creativity and my intellect and my energy and passion, to really do something much more meaningful. So that's what I'm saying. That's the most ethical thing. And the most unethical thing is for you to waste your time chasing after money or chasing after fame or tenure or something like that, where you should be focusing on helping people. Because there's nothing better than that in the world. There's nothing more valuable and more rewarding than to alleviate human suffering from injury and from disease. There's nothing more valuable, I think, that you could possibly do.
Wow. Can I just say something? Your point earlier that you made about ethics, I just feel like if you don't have this exposure and you're not like, I'm not saying that others don't, that they have, empathy, but I'm just saying that this seems such an important part of any kind of education and that it should happen as early as possible, right? It's not something that you just show up one day and say, gosh, I have empathy. So it seems to me like this should be pervasive. And as you said, it's not, right? It's not taught in a consistent way or, widely taught. I mean, I only know a few classes, if any. You talked about the patient, the provider, the payer, et cetera. But you can imagine someone playing the role of each and coming together around a technology and asking those questions. I mean, role playing from the perspective of the person who's going to be a stakeholder. But that seems to not be so common. So I just wanted to applaud you for emphasizing that, because I think for me, I need to be more deliberate about creating a culture, not just a class. Which is why I think like this environment that you've created is much more than just technology, right? It's about a way of being, a social norm, if you will. So I just wanted to, applaud you and thank you for that.
Thank you so much. I think your idea of role playing is really a great way to get started on that, developing those empathetic skills. Thank you so much for this wonderful opportunity. I really appreciate it. Excellent questions. Thank you all very much.
Yeah, thank you, Yusuf.
Thank you so much for coming. It is 12:59 and I want to be respectful of people's time. So I'm just gonna say a few closing words and then maybe if people have lingering questions, we can hang out a little bit. But I just wanted to say thank you to everyone for coming. Thank you to our guests for speaking. We are going to be hosting our next Global Health Leader Seminar event in January, and I just sent the RSVP link in the chat. So you can go ahead and RSVP for that now if you want. Also, you can follow along with us on social media. We'll be posting more details as we get closer to the event. But yeah, we're just really appreciative of everyone who came and took the time to ask questions and engage with us today. You guys have been fantastic.
Yeah, and let's thank, I know it's not the traditional way of thanking, but Yusuf, it was amazing. And I'm grateful that you spoke to all of us.
You're quite welcome. Thanks for the invitation. I really enjoyed it. Good luck.
Bye. Bye-bye.